I couldn't decide who should go first with this. We couldn't tell really which one was older, so we flipped a coin and I won. But before I start, I want to correct an omission that I made last June when I talked at the history thing, and I failed to mention two of the key people who are adding so much to our knowledge of black lung, namely Anita Wolf and her group, and Scott Laney and his group. They're really excellent people. And we're also going to meet a little later, very fine addition to the team, Dr. Akshay Sood. We'll hear more about him later. But I'm going to start this discussion about age and lung function. The fact is we do not have really adequate information about what the average lung function is among older people. First of all, how do you define who's normal when you have a whole lifetime of whatever might happen? We can rule out cigarette smokers, but the rest of the environment, we really don't know much about it. Now, in fact, there aren't really very many good prediction values for elderly people. A number of the schemes don't even include elderly people. For example, the Knudsen value formula doesn't include older people. So that's one problem. The other problem is that something we noticed back in the 60s was that our 65-year-olds were healthier than our 45-year-olds, and the same amount of time, same smoking. But these are the survivors. These are either super better or they are the average that just have better survival skills. So there are so many things that we just don't know about the lung function in the elderly. But since I get to go first, I'm going to let Bob do all the work. So I'm going to turn it over to him now.
Does this is working? I'll put this one down. Or you can hang on to that one in case. Oh, okay. So Don's going to chime in. I guess it's like the Department of Labor where they had the judge speak first and the young guy has to do all the work. So I'm not sure if I still qualify as a young guy, though. That's the problem. So we were asked by the organizing committee to talk about these different things that determine lung function. And really, when we talk about lung function, we're mostly talking about the ability of people to breathe in a normal way, and we measure that by spirometry by the FEV1. And really, for a lot of the lung function impairments that we're going to be talking about, the main disease process that we're talking about here is COPD, chronic obstructive pulmonary disease. So I thought I would focus on chronic obstructive pulmonary disease and how dust causes COPD and lung function impairment, how Don spoke a little bit about aging, and we'll talk about that, and then tobacco smoke and how those things all interact, because the minors that we evaluate that are disabled have lung function impairment, but they're older, they're dust exposed, and many of them smoke. And these three things acting together are why we often have a difficult time teasing out what causes what. I think that's why you guys asked us to talk about this, so I hope so. So just these disclosures, we're trying these days to be very apparent about who pays us to do things. So I'm a researcher funded by the Alpha Foundation, and I work for HRSA, as do many of you, and NIOSH and Department of Labor, and I still do occasional independent evaluations of minors and occupational lung disease. So I think today we'll define COPD quickly, how it's diagnosed and how it's studied epidemiologically. We'll talk about the role of age, smoking, and dust in the causation of lung disease, and we'll try to summarize some of the data from epidemiologic studies that have helped us and see what the policy implications of those studies are. So just a quick reminder, for chronic obstructive pulmonary disease, we really talk about chronic bronchitis and emphysema. And chronic bronchitis can be thought of as simple. If you cough and you produce phlegm, you cough and spit for 3 months out of the year, for 2 years, you've got it. You've got inflamed airways that are chronically inflamed, and as long as it's not from some other disease like tuberculosis or cystic fibrosis, then we say that's chronic bronchitis. We say it's complicated chronic bronchitis when that inflammation of your airways is so bad that it now affects your airways' ability to let air go in and out normally when you have lung function impairment. So when you do spirometry on somebody who coughs and spits for 3 months out of the year for at least 2 years, and that lung function is abnormal, they've got complicated chronic bronchitis. And then emphysema is what I like to fondly call Swiss cheese lung. That's when your lung is sort of destroyed, has holes in it. The airways become floppy because the nice normal spongy lung tissue doesn't support those airways normally. Then you get airflow obstruction from emphysema. And we know that smoking causes emphysema. We know coal dust causes it, among other things. And it causes chronic bronchitis as well. I'll just show these pictures very quickly. This is a normal airway, nice, juicy, normal alveoli with blood vessels. This is emphysema, where there's holes in the lungs, and you have loss of blood vessels, loss of air sacs. This is, I remember Dr. Petsank was showing us that really scarred-up looking lung that we saw with the rapidly progressive disease. This is nice, normal lung tissue. Look how thin and beautiful and delicate the alveoli, the walls of the lung are. And this is emphysema, where there's holes, and you just see destruction and loss of those nice air sacs. And here's an even worse picture of emphysema, where you have these large holes in the lungs. Again, Swiss cheese lung, and you can see that the airway, which is this structure here, wouldn't be very well supported, and it would flop closed and cause airways obstruction. Here's just, we see emphysema, but emphysema can also be diagnosed pretty well radiologically by X-ray. Chronic bronchitis is a little more difficult to diagnose by X-ray, but you've got these huge lungs, flat diaphragms. The diaphragm should be nice and curved. When you look at somebody from the side, this is almost as flat as a board on the bottom from an overinflated lungs that are blown up and cannot exhale normally. And this is a CT scan, and it's just a beautiful demonstration of all these holes in the lungs where there should be nice, normal, spongy tissue. Sort of like this tissue here is about the only normal lung tissue that this very emphysematous patient has. This is chronic bronchitis, where you have pus streaming down this red, inflamed, raw, ground meat-looking airway. And when we bronchoscope these folks, it's really nasty, and they cough their guts out, and it really is very unpleasant because the airways are very inflamed and covered with phlegm. This is asthma, where you have a lot of constriction and swelling of the airway. You can also get mucus, but the main feature that differentiates asthma is that it's reversible. These airways can become less swollen and less inflamed, and they don't have that chronic pouring mucus down their airways. I shouldn't do this after lunch, right? That's really not very... But I got your attention. Okay. And this is just an asthmatic patient that died of status asthmaticus, and this is an airway just plugged with mucus. So asthma can be very sudden, very acute, and very deadly as well. So those are the different things that compose COPD. A diagnosis is made. Usually people present with these symptoms. As pulmonologists or chest doctors, we're very simple people. We only have a few symptoms that we ask about. Do you cough? Do you spit? Do you wheeze? Are you short of breath? And that's it. And so that's all we have to learn. We can ask a few other things. But if you present with these symptoms of cough and phlegm and shortness of breath, and you're exposed to these risk factors that can cause COPD, we think about COPD, and then we go ahead and do spirometry. And you're going to have talks on spirometry as part of this, and it's our main bread and butter test as respiratory people. That's what we all do, and we do very well. So we make the diagnosis based on lung function. The most important measurement from our lung function testing is the holy and enshrined value of the FEV1. That's the most cosmically important and valuable number from lung function testing. All our patients are taught that they must know their FEV1s. The forced expiratory volume in 1 second, how much air you blow out when you're blowing as hard and as fast as you can in that first second. So we should have people knowing their own FEV1s just like they know their cholesterols or their blood pressure numbers. We think it's that important, and our patients' wives and husbands should be talking about each other's FEV1s in the barber shops and beauty parlors. Did you hear Harry's FEV1 is now only 30%, I predict? Anyway, but it's a very important number that people should learn and they should know. And the actual cut points to define COPD vary whether you're using international criteria from the Global Initiative on Obstructive Lung Disease, or GOLD, or if you use the American Thoracic Society. But essentially, the amount of air you blow out over the total amount of air you can blow out is less than 70%. You should normally be able to blow out about 3/4, but if you blow out less than 70%, that's abnormal, And if the FEV1, that cosmic number, is lower than the lower limit of normal, if it's abnormal, then you've got COPD. You've got this problem. It's a big problem. In our population, it's huge for minors. And it's huge for occupationally exposed workers to lots of respiratory hazards. But it's now, we were proud in 2010, pulmonologists cheered because we beat out the neurologists in that COPD overtook stroke as the third leading cause of death in the United States. So it's a huge problem. It's one of the few causes of mortality in this country as a whole that's getting worse. And in the world, it's a huge burden, not just in the United States. So I think that by 2020, in the world, it's in the whole burden of disease, that is if Ebola isn't taking over, it's expected to rank fifth in cause of death. And you can see coronary heart disease or stroke, COPD is the only one that's going up and all other causes are going down. So it's a huge problem for us, but not just us, nationally and internationally. So the causes of COPD, well, you've got to have a noxious agent. And we think of tobacco smoke, pollutants, and in our particular clinics, we always think of these occupational exposures. But it's funny that in almost all of the rest of medicine, people so rarely ask people what they do. They're trained to ask about smoking histories, they're trained to ask about family histories, genetic histories, but they don't ask people what they did for a living. And somebody shows up with COPD and it's often missed. And then we have the susceptibility factors, the things that make some people more sensitive than others. These hazards are not good for any of us to breathe, but some people are more sensitive than others and they get sicker. And so it could be genetic factors, respiratory infections, maybe when you were a child, you might have airway hypersensitivity or allergies, and then those sensitivities plus the noxious agents together result in this disease process that causes this lung function impairment. But we're really attuned to occupational exposures, but I must say that in the general medical community, occupational histories are very poorly done, and it's something that we're all struggling with. I know NIOSH is struggling hard to make this a bigger part of medical education. The process involves inflammation, where the airways and the lung tissue gets inflamed. It causes small airway disease and inflammation and scarring of the airways. We were talking about this morning when we were discussing the pathology. And then it can cause this destruction, these holes in the lungs, which leads to emphysema. And many people have both of these things. It's rare that you have just pure emphysema and pure airways disease. Most people are coughing and spitting and have holes in their lungs too, if they're sensitive folks and get COPD. And then they develop airflow limitation. They develop this loss of FEV1 that contributes to them being unable to breathe, ultimately being disabled and then becoming on oxygen and very, very ill. When we think about COPD, the natural history, I guess that's really an oxymoron. It's really an unnatural history. But people normally, as we age, we lose lung function with age. About 25 to 30 mLs every year we age, we lose some FEV1. I guess that's considered normal in our modern industrial society. But in smokers, it's averaged to be about 45 to 60 mLs a year. But a significant percentage of smokers, maybe up to 20%, are sensitive, and they lose huge amounts. And those are the folks that go on to get COPD from smoking. And the more your dose of tobacco smoke, the steeper the rate of decline. And so that if you smoke more, just like the more dust or other respiratory hazard that you're exposed to, the faster your lung function will decline. And this is a now classic graph, a work from Fletcher and Pito that was done in the 70s, but it shows a little young kid of 25 years old having a nice normal FEV1, and that it drops down as they age, and this is just a normal person aging. And you can see that they're not at the level where they would have symptoms of shortness of breath. They wouldn't be disabled, and they're certainly not dying from it. But if you're a susceptible smoker who smokes fairly often, look at that steep rate of decline of FEV1. And this will also apply to exposures to other hazards. But if you stop smoking, the curve generally sort of goes back towards normal. And the later you stop, the lower you are. So picture yourself in an airplane crash diving here. And at what point are you going to pull out of that dive? And if you pull out too late, then you're going to be disabled. And if you pull out later, then you'll die from this impairment. I think we've talked about some of these risk factors. Smoking is a huge risk factor. in the United States, especially in non-occupationally exposed populations. But other risk factors are air pollution, nutrition, I mentioned the infections, and some of these rare bronchial hyperreactivity is asthma. And then there's a couple rare genetic diseases, and we've had a number of miners that have had this. Those of you might remember Mike South, who was our president of the Black Lung Association for many years, had this problem and died from COPD from black lung related to this as well. But for us, we want to really think about these exposures. Occupational and environmental exposures, mainly coal dust and silica, are what we often think about. The problem when you think about trying to figure out occupational COPD from regular, general population COPD is that COPD, as I showed you, is a very common problem in the general population. So when a coal miner gets COPD, people just say, well, he's just like everybody else that has COPD, and there's nothing else going on. Don was just talking about the healthy worker effect, which is a problem in trying to figure out when working populations get sick, is that often people that work in these very heavy, difficult industries are healthier than the average person because you can't do this work unless you're very, very healthy. So it takes a lot more damage for them to be sicker, and when you compare them to the average person, they look better, even though for themselves they probably are affected. And the survivor effect that Don also mentioned, the 65-year-olds better than the 45-year-olds, because those guys were able to continue mining. They're also selecting out people that are really tough. So that makes it hard to study COPD in working populations. And it's also hard to study COPD in respiratory hazard exposed populations because you have to have good exposure measurements and good measurements of all these other things that cause COPD so you can control for them, so you can better understand the role of occupation. They're called covariates. And there's lots of problems in these kinds of studies of occupational CD because we don't often have good exposure. We just know how long people worked. And we're often using flawed data. For example, the compliance data is often flawed, and we've seen that in the coal industry. It doesn't mean there's no information in there, but it can be problematic. And smoking histories are often all over the place, and you don't have really great smoking exposure data. And then the other thing is that as you age, you also smoke more and you also work more. So they all track together. You're working more, you're smoking more, you're getting older. And so these covariates, they're called, they all track together. So that also, when you're studying these things as an epidemiologist or a scientist, it makes it harder to understand that. And then there's also other confounders, things that vulnerable populations may have had smoke exposure in the home when they're growing up, or nutritional issues or other illnesses that make it harder to study some of these things. And then one of the things we've been struggling with in our populations is that lung function can also be affected by weight gain. And we as a nation and in our population, and we see it in our miners, are getting heavier. I noticed this in Japan. I was there a couple weeks ago, and I couldn't believe how the whole population was really skinny because they eat fish and seaweed and and rice, and but we eat McDonald's. But in our country, we're suffering from a little bit of too much fast food, and the weight gain can affect some of these measurements, and that can be a confounder also. So in the best of all possible worlds, we'd have all the good testing, great medical records to review, and wonderful diagnoses. In reality, we're limited to some crude lung function tests and questionnaires. We often don't have access to great medical records, and we don't have good recall of people's histories. We're depending on their memories. We don't have real-time recording of their exposures. But I would just like to let you know that in COPD, even though the leading risk factor is tobacco smoke exposure, probably 80% of all disease, there has been a lot of work looking at what we call the population attributable risk of occupational exposures for COPD, and that there's a significant occupational exposure for COPD as well. And I'll take you through some of that in a minute. So certainly smoking is very, very important. I think that we should never cease our efforts to get people to stop smoking, to work on getting this exposure out of people's lives. It's hugely important. So we do in our treatment, in our therapy, in our clinics, I think smoking cessation is a huge part of what we all do and should be doing in our black lung clinics. So I think that's very, very important. But it's not the only thing. It's not just direct smoke exposure that is the cause. Workplace exposures, I think, are very significant. And there's lots and lots of studies that have shown that workplace exposures to vapors, gases, dust, and fumes is associated with the diagnosis of COPD. One of the seminal documents was written by the American Thoracic Society, which are the, as Debbie Wills likes to call it, the Dr. Gods of pulmonary medicine. So I guess that's what, I think she meant that in a nice way. But the ATS came out with a statement that was published in 2003, and they reviewed all the occupational links between COPD and asthma, and they were really trying to calculate the population attributable risk of occupational exposure to causing COPD. And they were looking for people that reported exposure to vapors, gases, dust, and fumes that we fondly call VGDF. Do you have any VGDF exposure? And that's what we teach our residents and fellows to ask patients in the clinics so that we can learn about this. And there were a large number of subjects in a large number of countries that were really reviewing people's reported histories of exposures, usually at least 6 months exposure to vapors, gases, dust, and fumes, and whether or not they were diagnosed with COPD or had lung function testing proving COPD. And those studies came up with a range of between 4 and 24% of the risk of the burden of COPD was from occupational exposure, with a median risk of about 15%. That's across the whole country. That's not in minors, because all of our minors are occupationally exposed, and therefore that risk is very high. When you look at it, measuring COPD by lung function, which is a harder standard than just a diagnosis of COPD, the range was also pretty similar in a number of countries. So if you can study things in large numbers of subjects and large numbers of countries, you know that it's real, that it's not something that's just a weird, strange phenomenon in the United States or something like that, or in another country. And again, a range of about, between 15 and 20% of all COPD has some significant component caused by occupation. So the ATS concluded that occupational exposures account for a substantial proportion of COPD. And so they were estimating at that time about 15%. And I just want to go talk a little bit in detail about some of those exposures, and then specifically some of the data on coal dust, and then I think we'll stop at that point. So for mineral dust, they're a huge and important contributor to occupational COPD. Coal mine dust, which we'll talk about, quartz dust, which is very potent, perhaps more potent than coal mine dust, anthracite coal perhaps being more potent than bituminous coal, and asbestos also have been shown in populations to have an excess incidence of obstructive lung disease, that these exposed populations, when compared to unexposed, have more disease. And then for occupational COPD, and I'm putting these other causes down because our miners often aren't only just miners. Many have worked in other industries, have other exposures, and these are things that you should be looking for. And in your clinics, you're seeing patients that are working in other industries. So these inorganic dusts, carbon black, ceramic, iron, steel, wollastonite, welding fume is a big one that affects miners as well because they're mining and they're welding, and cadmium fume, all have been clearly associated with lung function impairment and COPD, excess symptoms of chronic bronchitis. These workers cough and spit and meet the criteria for chronic bronchitis. And then organic dusts also, cotton dust. In agricultural areas in Illinois, we see grain dust exposed workers, and I'm sure many of you are working in agricultural areas. Wood dust has been associated with coughing and chronic bronchitis and lung function impairment. And even nuisance dust. You work in a warehouse and you're packing boxes of paper or whatever, and the sun shines through the little slit in the roof, and you see that all this dust in the air. And people say, that's just a nuisance. Well, it actually is more than a nuisance. It's been associated with chronic bronchitis and lung function impairment. And especially, if you go into an incredibly dusty place, you start coughing. So that's not a good thing for your lungs. But to focus just a little bit on coal before we end, the data on coal dust and COPD and chronic bronchitis is probably the best of any occupational exposure. It's been studied, very, very elegantly. in Europe in the pneumoconiosis field research group in Great Britain, and our wonderful group of scientists at NIOSH and our National Study of Co-Workers Pneumoconiosis. But these studies have clearly showed a relationship between years of exposure, when you add up how much dust somebody was exposed to the symptoms of cough, sputum production, cough and phlegm, wheezing, and shortness of breath. And these exposures, cigarette smoke and coal dust, are independent. And you can add them up, and you can see that the coal dust is important and additive to cigarette smoke. They're both important, and they both seem to be relatively equipotent. They're similar range of potency in terms of how toxic they are and how they cause these symptoms. And that the symptoms of chronic bronchitis correlate when you measure people's lung function. So if they're having this airway inflammation symptom, that people that had that symptom for the same level of exposure actually had more loss of lung function, which makes sense. And one of the interesting things that we certainly see is that even after you stop working and stop getting exposed, it's been shown that lung function can continue to decline even absent further exposure, or even when you're away from the mine. And that's probably not as true of smoking, where when you stop smoking, your lung function decline sort of goes back towards a normal rate of decline. This is a great picture that I got from Frank Green showing coal dust emphysema. And you can see the same kind of picture that I showed before of emphysema, of these holes in the lung, but all the pigment and all the coal dust deposition in a coal mine dust emphysema. This would look the same on X-ray pretty much. And it would be hard to tell the difference between this X-ray on X-ray compared to somebody with smoking-induced emphysema alone, unless they also happen to have some of the round scars or interstitial lung disease. But this relationship between emphysema and coal mine dust is also one of the best worked out occupational causes of emphysema. And that's been very, very elegantly done in these large autopsy studies where you compare people's smoking history, their coal dust or coal mining history, and the pathologists, they go around and they kind of score how bad the holes are. If your lung is full of holes, then you have a score of 10. If you have just a couple holes, a score of 1. And they would use sort of a semi-quantitative way of calculating how severe emphysema was and relating that to exposure. And the relationships were astounding. They were striking. And here you can see that this data comes really from the 70s and 80s, was continued on into the 80s, that the amount of emphysema is related to coal dust content. And in non-smokers, only coal dust content and age cause emphysema. And it is true that emphysema is also caused by aging. In our modern polluted industrial societies, if we just are around long enough and live long enough, we'll get a little emphysema of old age. And this, I think, was a seminal landmark study that Eileen Kumpel from NIOSH, along with Francis Green and others at NIOSH, did a great analysis of the National Coal Workers Autopsy Study. They graded emphysema severity, and the exposure to dust was known. They had cigarette smoking histories, and they found that coal dust, smoking age, and race all were significant independent predictors of emphysema severity. And we've gone over this article when it came out. Eileen Kumpel came to this meeting and presented the data. It's really a phenomenal study and should be part of any medical legal evaluation of an emphysematous patient that you're doing if they're also coal dust exposed. This is one of the sort of biblical studies, I think. It actually made the cover of the Blue Journal, which is the Dr. God's ATS landmark journal. And these are some photos showing severely emphysematous coal dust coal miners' lungs. And just some of the data from that shows the emphysema scores. The higher the score, the worse the emphysema. So for never smokers, coal miners almost 300 compared to 46. Smokers, 392 compared to 152 for smoking miners and non-smoking miners. And these differences were huge. So the amount of emphysema was dramatic and striking related to their coal dust exposure. And they had a nice number of non-smoking miners to take out any possible question that it's only the cigarette smoking that's causing the emphysema. And then if you look at the dose in terms of the years worked underground, there was a coefficient, which means a relationship, where that emphysema score went up dramatically, incredibly statistically significant for each year worked underground. And then year smoking and age were also important, but look at the effect of the mining, really a very strong effect compared to that of smoking or age. They're all significant, but the mining is huge. and very, very important. So I recommend that you sort of reference or read this article. If you're feeling that you can't go to sleep and you need something to help make you drowsy, it's a great article to read. But it's actually very, very good. So we talked about chronic bronchitis being importantly related to coal dust. We just talked a little bit about emphysema, which is important. And then there's been a number of studies that look at lung function impairment just measured by spirometry and coal dust exposures in mining populations. And it shows that there's very strong and important relationships between loss of lung function and your exposure to coal mine dust and silica dust. Both in the loss of FeV1, that's the amount that is most important, how much you get out in 1 second, but even the total amount, the vital capacity is how much you can blow out from being completely full to completely empty when you're breathing. And it doesn't matter whether or not you have radiologic pneumoconiosis, you still could have deficits, and the deficits were still important even when you took out people that had X-ray changes. So you got all the miners, you took out anybody that had a positive X-ray, you looked at the rest of those miners and compared their dust to lung function, and the dust was still important. And I also wanted to add that silica, even alone, is a very important cause of COPD, and even Nizdo, who was at NIOSH, and the late Dr. Val Valyathan did some wonderful work on this as well. So I'm just going to show you that different study designs, different ways of looking at it, different countries have all shown the same thing, just to prove to you that this is not just me saying this in one little tiny study, but it's really important. So decrements of lung function have been seen from dust in 5 major studies. Mike Atfield from NIOSH and HODIS in 1992. This is a very important study that we quote all the time, looking at experienced miners. Noah Satius with Mike and others, we looked at the data in miners that only mined after 1970, so relatively new miners. And this study was very important because it showed that people who first start mining have an accelerated decline in lung function in the first part of their mining tenure, maybe the first 5 years or so. And then it still goes down quickly, but at a less quick rate. So there seems to be some inflammatory reaction that occurs early in people's mining careers, perhaps, that is very important. So I think that was an important study. And it happened in Britain. And so it's not just something bad about American coal. It's also British coal and German coal and any other kind of coal. Because some coal companies would say that the British data didn't apply because that was British coal. It wouldn't happen with red, white, and blue American coal. No, sir. And then if you study the same person over time, and we've got a lot of data now, thanks to Anita and the Coal Workers Health Surveillance Group, because we're studying miners over and over again, and also we've got data from the national study of coal workers' pneumoconiosis, which went back several times. But I think now that we're doing more spirometry, we're going to update a lot of this, showing the amount of lung function lost over years. And it was all related to, significantly related to their coal dust exposure, that if you add up how much exposure they had and looked at their lung function, there was increased loss of lung function related to how much exposure to dust they had. I think I said this about chronic bronchitis. Okay. And this is just a summary of how much loss per amount of dose of coal dust. So there's a little bit of variability in these numbers. This was the younger miners here. That was a lot more. But you can see that there was a nice amount, a very significant relationship between how much loss of lung function per unit of dust exposure. So they took careful job histories. They related those job histories to sampling data to see what the exposures were in those jobs. Then they added it all up to see how much, say Jerry was working in a mine, how much dust Jerry had over his 30 years of a mine as a roof bolter, continuous miner operator, and then they looked at his lung function. That's a very elegant study, and these studies came up with this information, much more accurate than looking at someone's just the number of years that they worked, if you know their job and you know what the exposures were. And I just wanted to show that we just are doing a little bit of work. David Blakely, this young whippersnapper over here, has a spearhead study looking at chest X-ray findings and lung function. And we often used to say that lung function in simple pneumoconiosis wasn't a problem, or many textbooks say that if you have simple pneumoconiosis, there's no lung function impairment associated with that. Well, David looked at all the spirometry data that Anita's group got and showed that as you have more small opacities, even with simple pneumoconiosis, this black line is FEV1, which sort of makes sense that as you get more scars, you're going to have a loss of lung function as well. So this may not be COPD, or it might be some of the emphysema, but it's probably that scarring process causing lung function impairment. So one of the factors besides age and smoking and dust is the effect of dust causing scarring. And those who get scarring, this is not yet published. This is still a work in progress, so it has yet to be peer reviewed, but I think it's going to be an important study. So all of this has really made us decide as a country, and that's why MSHA issued this rule back in May, and why NIOSH on August 1st, was it, Scott? Something like that? When the NIOSH rule went into effect, I think, mandating spirometry surveillance of active minors in addition to chest X-ray surveillance. And that's huge because we know that this population has the triple threat or quadruple threat, if you throw in the scarring, to their lung function impairment. What is the quadruple threat? Aging, smoking, dust, and scarring. So if you think about it, they're really at a very, very high risk, especially if they're sensitive or they're overexposed, to having declines in lung function. So NIOSH has now, or MSHA has mandated, and NIOSH will be supervising and training people to do surveillance longitudinally of lung function in mining populations. And it's causing huge headaches for a lot of people because they're not geared up yet, and we're trying to do this, I think, on the fly in many ways. But it's an amazing and heroic effort by NIOSH to get up to speed to be able to provide this capability. It also means that all of us in our black lung clinics, Anita was calling for us to become screening sites for surveillance for X-rays, but we all have to get NIOSH certified for our spirometry training so that we can help provide that surveillance to minors. It mandates NIOSH trained spirometry technicians. So that's really important. So we have a course next week in U of I. If anybody needs to get their training, we can come to Chicago. So medical monitoring has long been a part of surveillance for COPD. This is the cotton dust standard, which I think it was late 1970s when that went into effect. And we're only just now getting surveillance for coal dust. But it's asbestos. There is some regulation that you should include spirometry for asbestos exposure as well. Benzene-containing petrochemicals, and certainly cotton dust has been a long part of this. But I think it's very important that we think of all these different factors, of all these exposures in people's lives that can contribute to lung function impairment, and certainly the more sensitive ones will develop disabling lung function impairment, and those are the ones that we are seeing, diagnosing, trying to get compensation, treating, and rehabilitating in our black lung clinics. So I don't know if I probably went over, but I'll stop there.
Any questions?
Akshay?
So this is a talk that only Bob could have given, so fast and so comprehensive.
Probably too fast.
No, it's just very well done. So Bob, and actually Dr. Rasmussen as well, and anyone else who can answer this question. So the lesson that I learned from your talk is that aging in non-smokers, the lung health study, the general rule is that the aging causes about 25 to 30 ml decline a year, right? That's the general teaching. It's clear that different people decline at different rates, and some people never decline. I don't quite know why, but they don't. The question I wanted to ask you is, do we know what the aging effect in in minors is? Is it the same as the 25 to 30 mean that's described in the general population, or is it much less because of the factors you mentioned, healthy smokers effect and survivor effect, because they're just healthy to begin with? So the effect of aging, independent of the coal mine dust exposure in mining populations, do we know what that number is?
I saw Don moving the microphone to speak, so.
We really don't know. But a lot of miners don't live long enough to reach old age, so we can make the measurements. I know that we have a sizable elderly population of miners from whom we can find no abnormalities. But I can't tell you, which end of the scale these people are on, or what should be normal. I don't think there's any data that would tell you that.
I think it's unknowable, because what you're saying is that the population that we draw our miners from, how would they age unexposed and non-smoking? So I think that that's sort of...
I mean, in statistical models, they can adjust for the mining, at least statistically
I'm
adjust
not aware of
smoking and mining effects and come up with an aging effect.
Not aware of the data. Yeah.
The second question I wanted to ask you was, the prevalence of pneumoconiosis in coal miners is described sometimes in your reviews about 5 to 6%, if I'm correct. But what is the prevalence of COPD in miners? At least in our in our population, clinical population, we see 3 COPDers to every 1 pneumoconiosis. But what is the prevalence? Does anybody know? Has it been studied and described?
It's done in the NIOSH Enhanced program has data. Lee, you want to answer that?
No, it's basically the data that my colleague Mei-Lin Wong published about 2 years ago showed exactly between 3 and 4 times as much abnormal spirometry as radiographic pneumoconiosis. Pretty much the same idea. And in fact, I think, David, just you want to mention your recent
There's about 3 times, like you said, in the May 1 study, and then the recent work that we did, the findings were we did some more recent work, and we were more specifically focused on small mines, but our findings were generally in line with May Win's. We had a few extra years of data, but it was about 3 times the amount. And
do you have percentages? Like, was it 20 in the 20% or something? It was fairly high, right?
Yep, it was close to 20%.
Yeah, that's what I recall.
And more in small mines.
So that's a pretty high rate. 1 out of every 5 miners with with significant. That was abnormal spirometry. So
abnormal, so obstructive, restrictive, or mixed bags.
just one of the questions that comes up sometimes is used by certain physicians regarding the cause of the impairment. I noticed you showed, and I think most of the studies show, that both the FEV1 and the FVC decline with increasing dust exposure. And so I think some people say, well, if there isn't a similar decline, that it can't be due to dust. Do you want to comment on that argument?
Yeah, that spurious argument. I think that the studies that have shown that there is definitely declines in FEV1 related to dust and declines in FVC, and then actually the declines in FEV1 are a little bit more accelerated than those in FVC, such that the ratio also declines, which means that there's an effect causing obstructive impairments with dust exposure.
Well, so let me just ask you then, in any individual miner, can you make a statement about the cause of their impairment based upon the pattern of spirometry?
You absolutely cannot, and Don is shaking his head emphatically as well.
Especially when you have a miner who's a smoker. How in the world could you say that the loss of FEV1 to FVC is due only to the smoking? That's nonsense. And even the people that first talked about this, like Sutar and Hurley, they just simply said their smoking miners look just like any other COPD patient.
Yeah, I mean, people have tried, physicians that usually work for operators have tried to say that because the pattern of spirometry is a certain way, I can say that it was only the smoking that affected him and not at all the coal dust, which is just sort of, fantasy, really. But thank you very much. Thank you.